some new diagnostic tools available. And this, hopefully I want to arm you with information to make decisions and help navigate the course of your illness. New drugs and blood and marrow transplant. Okay, so we heard a little bit about this, but when we go to these talks, and I'm often asked to talk about blood disease in older adults because that's my area, really there should be some conferences for younger adults, and then because these are diseases of older adults, so really I think all conferences should focus on this with a few for the younger patients. We must remember, we know there's a growing population of older people in the United States, and you can see 65 and older, it's going up in number and absolute proportion. And actually, centenarians are now 1.7% of our population, and that's growing. So we're not just talking 65, 75, we're talking 100 plus. So if that makes you feel better in the room, if you're under 100, you're a baby. Does it feel good? Okay, good. Now, the blood diseases, if you look over to the right, this x-axis as we call it, most of the blood diseases or blood cancers are more common in older patients. There's a few exceptions with ALL, but generally, actually this title's a little bit wrong, but if you just go across all the diseases, they mostly keep going up as people get older, and people often ask me, oh, it would have been better if I got that when I was younger. That's not the case. You don't want to be 20 with the illness, but it is the norm to have an illness if you're 70s or plus. That's really more of the common scenario, and that's why we need these conferences. So a lot of people are getting older, and the diseases are more common in older people. Now let's talk a bit about personalized medicine, and I think the field has shifted in a really remarkable way from giving old-style chemo to hopefully therapy that works better, as well or better with less side effects. And just to again introduce this idea of personalized cancer therapy, we don't like to think of people anymore as just they have lung cancer or AML, but more we try to understand the diseases, we draw samples from the diseases, and we profile it, and we look for mutations or changes. And then using that information, we can give people a better personalized understanding of their disease, because every disease is a little bit different. And that serves three purposes. What we call prognosis, meaning just a better estimate of what we expect in the future. Right now, our crystal balls are always a bit hazy, but this is starting to clear it up a little bit for us, for you, the patient, versus just some general number. Oh, 3 months, 3 years, we don't know. So it gives us refines that. What's most exciting is what we call predictive ability of the markers. So when we do a panel and we learn something about the disease, it may be able to tell us what drugs will work for the disease. And that's what we're here talking about today, and you've heard many, many examples already. And the last part, which you haven't heard about but is just as exciting, is that sometimes we understand about the body itself and how well the body will handle the drug, not just the disease, but will you have unusual side effects that we have to avoid? And so if we have a profile of the patient, we can also try to avoid drugs that will be harmful to you, hopefully. And so the future vision, right now we're not here, but we're on the way, is each disease and person is different, and we might have a different pill or drug for each person. You've heard already about CAR T cells and immune therapy, and we're going to hear more about it. I want to briefly, though, mention checkpoint blockade, because these are some of the new evolving therapies for blood cancers. Essentially, the way I think about these drugs, very simply, is we've heard a lot about T cells already. Those are the quarterbacks of the immune system, the Tom Brady's or Peyton Manning's. Unfortunately, in Chicago, we don't have good T cells. But I say that. Okay, we're looking, though. We're looking. So what happens is the cancer cells are very smart. Usually we clear the cancer cells. There are a lot of cancer cells that develop all the time. While you're sitting here bored, the immune system may be clearing the cancer cells. But occasionally the cancer cells learn to avoid the immune system, and they camouflage themselves. And by doing that, the T cells no longer see the cancer well enough, and they can grow and proliferate. So some of these new drugs can take off the camouflage and allow the immune system. So to attack the cancer. And this is an exciting area, and you hear a lot about immune therapy. You've heard about the antibodies Dr. Vinu and Dinner discussed, CAR T cells, and now we're talking about allowing your own T cells, not changing them, but just allowing them to attack the tumor or the leukemia better, to basically take off the camouflage. The common examples of that are nivolumab and pembrolizumab are common examples. And nivolumab just was approved, actually, for Hodgkin's lymphoma that's returned after regular therapy. Okay, now the other part I want to talk about, because I didn't see it much in the other discussions, is tailoring therapy to your fitness. So if we think about your journey with a disease, and say you're driving the car, and the disease, we've got some very rocky waters ahead of us, and we're trying to navigate which road we should go. We have to know about the road or the disease, but we also have to know about the car you're in. How good of a car is it, and what will it get you over? And so that means we have to know about your age and your physiologic age, your fitness. More fit, we can offer you therapy that has more side effects. Less fit, we need to offer you therapy that doesn't have as many side effects. And so we're also and your doctors in the room, or your doctors do this, but we're getting better methods to do this. So, everyone's different beyond their regular age. So this young woman, now, she's handing out Girl Scout cookies. She's got a good attitude. She's pretty functional. So we wouldn't want to exclude her from treatment just because, she appears a little bit older. So this is called a geriatric assessment. It's simply a new set. It's not new, but it's a set of tools that we're using more and more in the clinics to assess people beyond what the eyeball test says. And we look across people's at health in multiple ways: their health conditions or comorbidity aside from the disease itself, their function. Are you playing 18 rounds of golf, or do you have to take the cart? Function, social support, who takes you to appointments, how well people's thinking and memory may be, the anxiety and depression, to what extent is it limiting you, nutritional status, and polypharmacy. And if we use all of those, we'll really get a good picture of how well someone is, how much they can handle, and sometimes we can find opportunities to improve your health, because we have to treat the disease, but we have to treat you as well. Now I'm going to turn a little bit to some of the new drugs available, and there's so many new drugs available, we won't have time to go over all of them. Dr. Venugopal already went over drugs for lymphoma, and some of those same drugs treat chronic lymphocytic leukemia. It's a similar disease, and you heard about antibodies already, obinutuzumab and ofatumumab. They're new approvals from the FDA in the past few years. And targeted oral drugs, these are the same drugs you heard about from Dr. Vinu for low-grade lymphoma: ibrutinib, idelalisib, and venetoclax, recently approved. Ibrutinib's probably the most exciting drug as far as changing the landscape of CML, so it's extensively used and expensively used. These drugs are very costly, unfortunately. There's some exciting drugs that are in clinical trials. So one of them, this drug you already heard from Dr. Venugopal, it's a BTK inhibitor, we call it. And there's this other drug that was just reported, and it's sort of like a super ibrutinib, and it's very exciting. Almost all the patients had a response to it, and so this is in patients with CLL that were previously treated. So I think this one is coming up, and I think we're just seeing more and more exciting treatments. And CAR T cells, which you just heard about and you'll hear more about, are also being used in CLL with a lot of excitement. Now, acute myeloid leukemia, we heard about acute lymphoid or lymphoblastic leukemia, AML. There have been a real dearth of new drugs for AML. So we've had no new approvals, but there is one drug that is being moved on toward approval status very quickly called midostaurin. And this is for a specific type of AML. So it again illustrates how we take a disease and find a subset. So of disease that historically it was harder to treat these diseases when they had this mutation called a FLT3. And now with new drugs to target this, we're doing better. So there was a trial just for example, where they took this new drug called midostaurin plus chemo, or people had chemotherapy alone, and the survival was much, much longer in people who had the drug plus chemotherapy versus chemotherapy alone. This drug isn't clinically available. We have trials and others do with it, but I do expect it to gain approval somewhat soon. And there are many other targeted drugs against FLT3 that are in trials today and against another type of mutation in AML called IDH, especially IDH2. They're being used for people where the disease did not respond to initial treatment and added to initial treatment to try to improve results. And there are a lot of new antibodies being tested, and we've heard about antibodies multiple times against these targets on the cell surface of leukemia. They're all in clinical trials. None of these are approved, and to be honest, none of these are quite close to being approved, but you may find them on a clinical trial. You've heard already about multiple myeloma, and I'm actually going to go past it, past all these new drugs because you heard about it. But what I think is my take on what's exciting about multiple myeloma is that with all these new drugs, it's figuring out the best recipe for each patient. We have so many new drugs and combinations, we don't know the best treatment for each patient, but we have a lot of tools available. I think the checkpoint inhibitors, you just heard about these drugs that activate your immune system, they can work in myeloma, and they're being studied. And then the whole concept in myeloma of is right now is that we treat people as well as we can up front, and we use autologous transplant, and then we go back to these drugs in maintenance. It's a lot of treatment. People stay on treatment, but with that paradigm, people are seeing very, very good results, much better than what we had seen 3 or 4 years ago. So that's really the paradigm in multiple myeloma right now. You've heard about ALL very nicely, so I will go right past it. Chronic myeloid leukemia. So that has been the hallmark disease. There's the Philadelphia chromosome is the major change in CML, so we have one thing to target. And so Gleevec or imatinib has been the standard bearer of what we call targeted treatment. And there are a lot of new drugs, but what I think is most exciting about CML is actually some of the patients may be able to stop their drug. And the drugs are so effective that it knocks the disease to such a low level. You heard from Dr. Dinner about MRD, and we have very good measures of disease, and sometimes we can't detect the disease by the most sophisticated tests. Do we know if it's cured? We don't like to use those terms, we don't know, but some of the patients are stopping the drugs when they're on trials, when they haven't found disease for some period of time, and about 50% of them, we don't detect the disease after 2 years of stopping the drug. So that's, I think, one of the most exciting parts about CML. Another thing to mention is a disease that probably no one in the room has. There's something called atypical CML or chronic neutrophilic leukemia. You don't have the Philadelphia chromosome, but it looks a bit like this one. And this speaks again to modern personalized medicine. The field has found that there's a specific mutation, this thing, CSF3R, that's only found, you can't tell looking at the microscope, but when we do the sophisticated studies and you look at this, you see, oh, this is mutated or changed, and you only see it in this disease, or almost only, and there's some drugs, this is ruxolitinib or Jakafi or dasatinib or Sprycel, which may be useful. So there are trials for this specific subset. So it's a very exciting time in the field when we find specific mutations we can target. As far as the last disease I want to mention is myelodysplastic syndrome and aplastic anemia, which we don't think of as a true leukemia or malignancy, but in MDS or myelodysplastic syndromes, we have no new recent approvals. So that's frustrating. Most treatment, or most people are treated with drugs called azacitidine or decitabine, Vidaza or Dacogen, and the trials usually add something to that. And so one of the trials I thought was pretty exciting, again, it's nothing approved, using this drug with azacitidine or Vidaza, the response rates were very, very high, 84% in a small number of patients. So it gives us hope that we can combine two drugs and be more effective. And anemia is a real problem with MDS. Even with growth factors and drugs to treat anemia, most people end up requiring blood transfusions when the disease is more advanced. And this was a study using this drug, and it was found that about 80% of people, again a small number, responded to this drug. They're in clinical trials. So I do think there is some hope on the horizon for MDS for drug treatment. Lastly, aplastic anemia, for anyone who has that or knows about it, not a malignancy, just the marrow is wiped out because of the immune system, so it's an immune disorder. But there's a growth factor called eltrombopag. It makes you grow more platelets or produce more platelets. It's been used in maybe other cells, and given regular therapy, if we give regular therapy that we do for aplastic anemia and add this drug on, it has been found recently that the response rates were really, really high, maybe 80% compared to normally 50 or 60%. It wasn't a type of study that's definitive, but I think it provides hope that we're going to do better with aplastic anemia too. This is not targeted drug, but if it works, it works. So I want to take some time, and I know any of us who are patients, you're probably sent things by everyone you know about a Parade magazine article. Has anyone not been sent something from a friend that said, "Oh, did you see this cure for cancer?" And and then you come to the doctor's office and they roll their eyes. And the problem is, I do think the press is not helping us. They're not helping us in politics, and they're not helping us in this field because, did I say that again? But the issue is that every disease is so different, and obviously what's being reported are some rare success stories, which are exciting. And so even this title, How to Cure Cancer, and then when you read the article, it says, oh, we don't have any cures, but what we need to do is build better teams. That's literally what the article says, but look at this. And so people send you this thing, they don't read the article. And I think that makes it very, very difficult, but I want to speak to it when people come to you and say, oh, Joe, whoever was 2 and was on Parade and they cured his cancer, and what about your myeloma? One of the issues, the cancers are so different, people are so different, and there's so many different targets. So for something to work, we have to have a very good target. We have to have a very good drug. It has to be approved and ready for you to use. And those are a lot of things to happen. So everything is so different that's why when one drug worked for a disease that was different, it's very unlikely that's going to be applied today for you. If it's the same disease, at least you can ask your doctor if there are trials about it. Okay, but I do want to touch on that a little bit. And I do think organizations like the Leukemia Research Foundation and others probably provide you a little better balanced description than Parade or Time about your disease. Okay, now you've heard some of this, a lot of talks already about transplant. So blood and marrow transplant still remains an important part of treatment for blood diseases, for almost all of the blood diseases. And you saw this slide, I think, earlier from Dr. Burns. So looking at the donor transplants, we have using your own cells, autologous, and using someone else's, allogeneic, we see a lot more people who are 60 and older getting donor transplants, both by number and absolute percentage. The same in autologous transplant, about 40% or more of people are 60 and older who undergo autologous transplant. And even in those people 70 and older, where historically people would say, oh, you're just too old, there's more and more transplant use in people in their 70s. These are donor transplants. This isn't a lot of people, but it's going up and up and up. And the same with autologous transplant. It's going up and up and up to about 3% of all transplants are those 70 and older. So it's not that it's commonplace and we offer it to everyone. They do get screened, but it's not excluded simply due to age alone. And the NMDP has helped us tremendously by finding good donors and good cords for patients. And one of the ways we do this, informally the doctors assess your health, and then we've developed a program to more formally assess someone's health to see if people are well enough to undergo it and how to get them through a transplant. And I think this is something evolving that you'll see over the next decade being more utilized. So in our practice, we do an assessment. You saw the tools that we put people through, and we have a multidisciplinary team that sees people. It's about a 6 or 7 hour visit, and then we have a team meeting to go over the patient's health to see if transplant's a good idea for someone who's older and how to get them through. And what I really want to emphasize from this is that as we move ahead, and we have to really have a team approach, and sometimes right now the medical community hasn't, we don't have teams as people are older to necessarily deal with problems that people might get when they're older, say toileting, urination, falls. And so right now people are trying to develop teams, but sometimes you as the patient or the caregivers actually have to be an advocate and be aware and help navigate all the different doctors and decide the role of your generalist or a geriatrician or someone else in this. But I do think this type of approach in the future will help us, and especially help us in survivorship when people are being treated long term. Oh, I cut myself off. So in short, personalized medicine is here. Each cancer and patient requires a different treatment. New drugs and immune therapy are improving success. And for fit, older patients, transplant may be an option. I appreciate the time. Thank you.